first step to confirm, and I would say to substantiate a suspicion, a strong suspicion of DMD, would be to dose CK in blood. And usually patients are referred to tertiary centers already with a CK value. And CK in Duchenne is very high, so its values in the thousands, usually 10,000 and above. And sometimes we are referred patients who are somehow weak or struggling to keep up with peers, but they have lower values of CK, maybe in the hundreds, and then can be indicative of other neuromuscular disorders, but usually Duchenne is ruled out if CK is not at least in the thousands. And that's the first step. And if the suspicion is strong, so very high CK in the thousands and a suggestive phenotype with calf hypertrophy, Gower sign, then we would go directly to an MLPA testing, because that is able to identify 60 to 70% of DMD cases. And if this comes back negative, a few years ago we would have still gone to a muscle biopsy to look for dystrophin protein, but now as sequencing becomes less expensive and more accessible, we usually go directly to the sequencing of the full coding sequence of the DMD gene, looking for smaller mutations, nonsense mutations and other mutations. And if that comes negative, then really it is crucial to investigate the protein and run a differential with other limb girdle muscular dystrophies, which can also have a Duchenne-like onset in young kids. And if sometimes it happens that the coding from genomic DNA, sequencing from genomic DNA is normal, but dystrophin is absent, then we have to look for the rare mutation by studying cDNA transcribed from RNA in muscle. But these are just a minority of the mutations.